Hello, everybody. Welcome to the fourth webinar for the ECMO and Mechanical Circulatory Support course. This course is brought to you by Saving Lives Academy. The course is online. It spans 12 weeks. It includes 4 modules. We are currently just starting the second module. The first module focuses on the basics of ECMO. The second module focuses on VV ECMO for ARDS and respiratory failure. The third module focuses on VA ECMO and cardiogenic shock. The fourth module focuses on mechanical circulatory support. The entire course is 12 weeks in duration. There are MCQs pre and post module, and there are online lectures. Saving Lives Academy has also launched an app for you to enroll in this course online and watch the videos from your cell phone. The app can work on both iPhones and Androids. And so I welcome you to this course. And today we have 2 webinars. I'll hand it over to Ahmed to take it from here. Everybody.
Thank you, Dr. Higazi. Welcome, everyone. I am Ahmed Magdi, physician and ECMO physician. I would like to thank you for attending this meeting today, which is a part of our ongoing educational webinar series about ECMO and mechanical circulatory support. It's my pleasure and honor to be with you today as the moderator of this important session. We extend a warm welcome to all attendees who have joined us from various parts of the world, reflecting the significant interest in this vital topic within critical care. VV ECMO has become an important tool in managing acute respiratory failure that is refractory to conventional treatments. This technique has proven its effectiveness in saving the lives of many patients. However, choosing the optimal VV ECMO configuration remains a complex clinical challenge that requires a deep understanding. Should we choose FEM-FEM approach or FEM-JAG approach, a single cannula configuration or a dual cannula? What are the advantages and disadvantages of each configuration, and how can we make the best decision for the patients based on their clinical condition and individual needs? Today, we have an expert speaker in this field who will share with us his experiences and knowledge. Let me introduce Dr. Ahmed Higazi, who is an associate professor of critical care medicine and anesthesiology at Western University, Canada, and also he is a head of department of the cardiac surgery ICU at Medina Cardiac Center, Saudi Arabia. He is also one of the academic directors of Saving Lives Academy, leading advanced training in critical care and extracorporeal support systems. Dr. Higazi is an expert in post-cardiac surgery care, resuscitation, and ECMO management. He is also a recognized leader in competency-based medical education and a distinguished educator in point-of-care ultrasound and transesophageal echocardiography. This will be a wonderful opportunity to learn, discuss the latest developments, and exchange clinical experiences. We encourage all of you to actively participate, and please ask your question in chat box. Dr. Higazi, please, the mic is yours.
Thank you, Ahmed. Thank you for the kind introduction. So I'm going to be talking to you today about VV ECMO configurations. What are the pros and cons of each configuration, and how to pick your priorities? I'll first go through a case, and then we'll tackle this topic through this case presentation. And I have MCQs along the way, so please get ready to use your poll function to contribute to the questions. This case is a patient that I saw in my ICU in Canada. It's a 38-year-old male. He was previously healthy. He's 170 centimeters tall, 85 kilograms in weight. He presented with a high-grade fever and shortness of breath 6 days ago. In the emergency department, he was found to be profoundly hypoxic. He was intubated. His chest X-ray shows bilateral fluffy infiltrates consistent with ARDS. In the ICU, he was transferred to us. He was paralyzed. He was sedated, obviously, very deeply, and then paralyzed. And then he had a high PEEP with lung protective ventilation, as we normally would do for ARDS patients. His urine antigen was positive for Legionella. So he had a Legionella pneumonia or Legionnaire's disease. He was on a small dose of norepi, 0.05 mics per kilo per minute in the ICU, and his echo showed a normal LV, very mild RV dysfunction, but normal RV size. His PF ratio, his PaO2 to FiO2 ratio remained 75, So we proned him in the ICU. While prone, his arterial oxygen tension remained low. So his PaO2 remained 71 millimeters mercury while prone. He had a persistent fever, and the team decided to put in an ECMO consult. And so let me go through the topic that I'm going to tackle through this case. First, I'll introduce the configurations for VV ECMO and some tips and tricks about cannulation. Then I'll talk about the two-site approach, the femoral-jugular approach and the femoral-femoral approach. And then I'll cover the bicaval dual-lumen cannula, the single-site approach, and we'll talk about the pros and cons of each through this case that we're discussing right now. So let's start off with an introduction. So back to our case, this young 38-year-old gentleman who was previously healthy with ARDS, secondary to Legionella pneumonia, gets an ECMO consult. The ECMO team arrives. He is clearly very poorly responding to proning. His PO2 is still 71 on 100%, so his PF ratio is still 70 on FiO2 of 100% on the ventilator. The ECMO team arrives and they decide to go for VV ECMO. The ECMO consultant calls for the ultrasound machine. So we'll start off with a very easy question, and we'll build difficulty as the presentation goes on. So this first question should be an easy question for all of you. The next ones will not be as easy. So why did the ECMO consultant ask for the ultrasound machine? Why is ultrasound guidance recommended for VV ECMO cannulation? This is the first question. Is it because it eliminates the need for sterile precautions? Is it because it increases success rates and reduces complications? Is it only required for jugular access to avoid carotid puncture? Or is it because it replaces the need for echo? I'll give it a few seconds for people to answer that question. Okay, perfect. So most of us got this question correctly. So it decreases complications and it increases success rates. So that is the correct answer. And ultrasound now has become standard of care when it comes to line placements, let alone ECMO line placement. Ultrasound is recommended by the ELSO guidelines, and it is currently standard of care for central line placements, and so should definitely use ultrasound to cannulate a patient and put them on VV ECMO. There's two ways in which you can access the veins. The first is percutaneously, ultrasound guided, and the second is open techniques where you need a surgeon to do a surgical cut down. Percutaneous with a modified Seldinger technique is now the standard of care for venous access for VV and VA ECMO. The open technique, on the other hand, needs a surgeon to perform it. And so the open technique usually requires two incisions, one big incision to expose the vein and the artery, and a second small incision more distally to tunnel the cannula and so that its angle hits the vessel in a more of a shallow angle and for the stability of the open technique. And so it requires two incisions, it requires surgical expertise, and so it's quite limited in who can do an open technique. So why can't we just get the surgeons to do all of these? Open techniques should not be standard in most of our patients. In fact, there is literature to show that an open surgical cut down has higher infection rates than a percutaneous insertion. And so you end up with a higher risk of infection if you go for an open surgical technique, which makes sense. You're opening the skin with a big incision, and so you can end up with infections. The ability of the cannulators with a skill set is limited to surgeons when it comes to open cut down techniques, whereas it's widespread when it comes to percutaneous insertion with a modified Seldinger. The bleeding risk is actually lower with a ultrasound-guided percutaneous technique compared to an open surgical cut down. The speed of insertion can be quite fast with a percutaneous technique with ultrasound, whereas with an open surgical technique, it can be a little bit slower. And at the end of the day, when you're decannulating this patient, you actually need an operative reconstruction if it's an open surgical technique. This patient cannot simply you can't just pull the cannulas and pull and compress. You actually need the surgeon to take the cannulas out, do the purse string, close the skin in layers. And so you need an operative reconstruction to actually decannulate somebody without an open surgical cut down. Whereas with a percutaneous insertion, simple direct compression for an adequate amount of time is usually enough. And so there's evidence to show here that percutaneous insertion should be the go-to, should be the first line for inserting ECMO. This is a picture from a patient I took care of in the ICU who had an open cannulation for peripheral VA ECMO. And the wound at the end of the day after the surgeon decannulated, this picture was taken 4 weeks after decannulation. After the surgeon decannulated and closed the wound, it dehisced, opened up again. They had to put a vac dressing on it and wait for it to heal by secondary intention. And so this is not pretty. And so that's why we try to go with a percutaneous modified Seldinger technique with ultrasound in preference, and as opposed to doing an open surgical technique. And open surgical techniques are really a last resort, and you need a surgeon to get them done. I'd say it's not very common that you actually need it. If you're good with ultrasound and if you have enough experience, you're usually good enough putting it percutaneously with ultrasound. Now, what do the guidelines say? The guidelines published by ELSO on VV ECMO say that because most cannulas are placed with a modified Seldinger technique, they can be placed by appropriately trained either surgeons or non-surgeon operators. You don't need a cardiac surgeon to put somebody on ECMO. If you have a trained intensivist or anesthesiologist or a trained ECMologist per se, you can put somebody on VA ECMO or VV ECMO, and that's become standard in most institutions around the world. Like, why would you do an open technique if you can do a percutaneous technique? Why would you get an open cholecystectomy if you can do it laparoscopically? And so that is my analogy. So a little bit of a word about cannulas as well. Cannulas are sized according to their outer diameter in French. Remember, endotracheal tubes are sized according to their inner diameter. ECMO cannulas are the opposite. They're sized according to their outer diameter and usually measured in French. What does French mean? 1 millimeter equals 3 French, or you can say 3 French equals 1 millimeter in outer diameter. And if you want to know how much French this vessel can take, you can just measure the diameter of the vessel, multiply that by 3. The diameter in millimeters multiplied by 3 tells you how big of a cannula you can fit in that vessel in French. So say, for example, you find that the smallest diameter of this vessel is 8 millimeters. Go with the smallest, not the largest. So we find that the smallest diameter is 8 millimeters. You multiply that by 3. It tells you that this vessel can fit a 21 French cannula. Radius is the most influential parameter affecting flow, as we all know, and that goes back to the Poiseuille-Hagen equation, where we know that flow equals the difference in pressure between the start of the tube and the end of the tube, the delta P, multiplied by pi, radius to the power 4. So radius is the most influential parameter affecting flow through these cannulas because it's to the power 4. And you divide that by 8 multiplied by eta, which is the density of the fluid, multiplied by the length of the tube. So that is the Poiseuille-Hagen equation. And so the bigger the cannula you can fit, the better the flows, the better the respiratory support you can give to your patient. And so I always say the cannula size or the radius of the cannula is actually the Achilles heel of ECMO support. If you put in too small of a cannula for a patient and you're stuck with lower flows, you will be stuck with lower flows for that entire ECMO run, and they may not be sufficient. And so I typically will say put the largest diameter that can be fit comfortably within that vessel. Now, obviously, the larger the diameter, you will have some other complications, like you can have vessel occlusion. But at the end of the day, if the patient has life-threatening ARDS and hypoxemia, you do want to give them the best chance possible. And so I would err on the side of putting in a larger cannula to support this patient. So let's go through the two-site approach. And there's two approaches here. There's the femorojugular and the femoro-femoral. Femorojugular versus femoro-femoral. I'll start off by asking a question. If I want to put a patient on VV ECMO, and I'm going with a femoro-femoral approach, where should the cannula tips be positioned? So here, should I put the drainage tip in the femoral vein and the return tip in the opposite femoral vein? Should I put the drainage tip in the right atrium and the return in the inferior vena cava? Should I put the drainage in the inferior vena cava and the return in the right atrium? Should I put the drainage tip in the intrahepatic IVC and the return in the femoral vein? So let me know what you think. Let me know where the tips should be located if we're putting somebody on VV ECMO through a fem-fem approach. I'll give it a few seconds. Okay. All right. So looks 55% got the correct answer. So that's most of the attendees, so that's great. The drainage tip should indeed be in the inferior vena cava, while the return tip should always be in the right atrium. Now, always remember, return, right atrium, return, right atrium. So let's go through the configurations. So here, when you're doing a two-site approach, the femoral jugular approach tends to bring a cannula in the femoral vein and advance it into the IVC, and that would be your drainage cannula. The return cannula will be through an internal jugular cannula that is advanced into the right atrium. So you drain the IVC via the femoral vein, you return to the right atrium via the internal jugular vein. That's called a fem-jug approach. On the other hand, if you were to go with a fem-fem approach, you would drain the IVC via the femoral vein, and you would return to the right atrium again via the other femoral vein. So you would advance your return cannula all the way up the IVC until you reach the right atrium. So notice here, return to the right atrium in both the fem jug and the fem approach. Return always to the right atrium. And so this is extremely important. And why is that important? It's because if you reverse the order of these, you'll get recirculation. So here, as I said, return cannula must be in the right atrium. So let's think about it. With the first approach here, with the fem jug approach, you're draining the IVC, which is great. 60% of the venous return going back to the heart comes back to the heart through the IVC. So you may be catching up to 60% of the venous return by draining the IVC. And then you're returning to the right atrium through a jugular cannula that is advanced all the way down to the right atrium. And so that flow, or at least most of it, should go down the tricuspid valve to the right ventricle. And you should be pumping oxygenated blood down the right heart and through the lungs. On the other hand, if you look at the fem-fem configuration, you're withdrawing blood from the IVC, but you're returning blood to the right atrium. If you were to flip this, if you were to actually withdraw blood from the right atrium and return it to the IVC, you'd have massive recirculation because you'd be returning oxygenated blood to the IVC, and that oxygenated blood would be sucked back into the drainage cannula. So always, the return should always be in the right atrium. Never confuse this. Return right atrium so that you don't get recirculation. So when placing a patient on VV ECMO with a fem-fem approach, as we said, drainage tip in the IVC, return always in the right atrium to avoid recirculation so that your returning oxygenated blood lands in the right atrium and then goes through the tricuspid valve, through the RV, and through the pulmonary circulation. So remember, we're only providing respiratory support here. We're talking VV ECMO. We're not providing any circulatory support. So when you look at the cannulas, drainage cannulas are usually long and multi-stage, meaning that they have multiple side holes. So if a side hole gets blocked or gets up against the wall of the vessel, you can drain through the other side holes. And so drainage cannulas are usually long and multi-stage. Return cannulas can be one of two things. They can be short and single stage. So this would be a short single stage cannula that has an opening, a distal hole here, and has a wire reinforced portion that prevents collapse of that cannula. Now, mind you, remember when you're actually clamping, you need to clamp the non-wired portion or the unwired portion. Never clamp the wired portion, or else it will close the lumen and you'll never be able to open it up again. You may need to replace that cannula. So the return cannulas, as I said, can be short and single stage. If you're going with a fem jug approach, the jugular site is close to the right atrium. You don't need a long cannula. But if you're returning to the right atrium via the femoral approach, you'll need to advance it all the way to the right atrium. So you'll need a long single stage cannula that you will advance all the way up to the right atrium from the femoral vein. And so with a two-site approach, with the fem jug approach, you're draining, as I said, the IVC. Usually the drainage cannula that you'll put in is about a 25 French. By default, I'll usually put in a long 25 French multi-stage for my drainage cannula. However, that size will vary depending on the size of the patient. Could be as small as 23, could be as large as 29. Pediatric sizes will sometimes need even smaller than 23, sometimes even 21. But generally speaking, if you were to put a 25 French long multi-stage, for most patients, that will be just fine. Now, the return will be a short single stage cannula, and usually I try to go with either a 19 or a 21 French short and make sure that the tip is sitting in the right atrium. On the other hand, if you're going with a fem-fem approach, as I said, you're draining the IVC by the femoral vein, you'll still need the long 25 French multi-stage for your drainage cannula. However, for your return, you will need a long single stage. Either you can put a 23 or a 21. Usually we put in the drainage cannula larger than the return cannula, and the drainage cannula is usually the rate limiting step. The drainage cannula is the rate limiting step for how much flow you can run. The larger the drainage cannula you can put in, the more flow you'll be able to afford, and the more venous drainage you'll be able to attain. And so usually 25 French drainage in the IVC, and then return through the other femoral vein up to the right atrium with a 21 or 23 French single stage all the way up to the right atrium. So that is the cannula size that you'll use. Now, mind you, with a fem-fem approach, you need to be aware of one issue, is that the cannula tips should not be too close to each other, or else what you will get is recirculation. That oxygenated blood being pumped into the right atrium might get sucked back into the drainage cannula, which is what we call recirculation. So that oxygenated blood will not be going to the patient. It'll actually be oxygenating the circuit and leaving out the patient. And that'll be the title of our next talk and our next speaker. So I won't dwell on this too much, but what you need to know here is that if you're doing a FEM approach, the risk of recirculation is high. What you need to do is you need to have the return and the drainage cannula spaced apart. Now, some authorities will say they should be at least more than 8 centimeters apart. Most people would say try to go with 10 to 15 centimeters apart, but at a minimum, they should be more than 8 centimeters apart. If they're anything less than 8 centimeters, you will definitely get recirculation. If you get recirculation with 8, you need to go to 10, 15 centimeters apart, which is recommended by some authorities. And so let's go to the next question. If you were to put in an adequate sized cannula, which VV ECMO configuration will give you the largest amount of flow and hence will give you the largest amount of respiratory support? So let's pull up the poll and let's see. So you're deciding now which configuration to go with. Which configuration will give you the largest amount of flow? Is it the FEM-JUG configuration? Is it the FEM-FEM configuration? Is it the bicaval dual lumen cannula approach? Is it the jugular subclavian configuration? So pick your choice. I'll give you a few seconds. Okay, so 50% got FEM-JUG, which is the correct answer. And so the correct answer is femorojugular. Most of the time, if you have an adequate sized cannula, will give you the largest amount of flow. So let's look at the largest amount of flow that can be afforded by the different setups. So with a FEM-JUG approach, you can sometimes reach up to 7 liters of flow, potentially. We rarely reach that, but potentially if you have large enough cannulas, you could get up to 7 liters of flow. Now, FEM-FEM, you can get up to 6 liters of flow. Now remember, with the FEM-FEM approach, your return cannula is actually really long. And so there's a bit of extra resistance here. Remember, more length in the cannula means more resistance. And so typically your return cannula, because it's so long and there's a bit of resistance there, you may not be able to get as high flows as the FEM-JUG. With the FEM-JUG, you have a very short return cannula, whereas the FEM-FEM, you have a very long return cannula advanced all the way up to the right atrium. So you can afford up to 6 liters or so with a FEM-FEM approach, whereas the FEM-JUG, usually you can get up to 7 liters theoretically, although a lot of times we're not able to get up there. As I said, the cannula length will need to be long with a FEM-FEM approach with a return cannula. The recirculation risk is higher with the FEM-FEM approach compared to the FEM-JUG approach. And so the correct answer here was femorojugular. Now, mind you, we'll go through the bicaval dual lumen cannula in a second, and we'll go, the jugular subclavian configuration is not actually a VV ECMO configuration. That's a VA ECMO. configuration that is rarely, well, not rarely, not very commonly used. You can drain the jugular and return to the subclavian artery. This is not VV ECMO. This is VA ECMO. So this is definitely an incorrect answer. The bicaval dual lumen approach will usually give you up to 5 liters of flow if you use a 31 French. So the correct answer here with femorojugular could give you the largest amount of flow. And so let's go move on to the single site approach or the bicaval dual lumen cannulas. And so we'll start with a question. Which of these is an advantage of the bicaval dual lumen cannulation approach when you compare it to the classic femorojugular approach? Does it have a lower cost? Now we're talking the advantage of the bicaval dual lumen. Does the bicaval dual lumen have a lower cost? Does it allow prone positioning and early mobilization? Does it eliminate the need for anticoagulation? Does it provide higher maximum flow rates? Or does it avoid the need for imaging during insertion? Which of these is an advantage of the bicaval dual lumen setup? All right, so the bicaval dual lumen setup correctly, as most people answered, allows prone positioning and allows early mobilization. So that is the correct answer. It's a single site cannulation approach. You go through the jugular down to the inferior vena cava, and I'll show you in a second how it's done. And that, because it's a single site approach, you don't cannulate the femoral vessels, you allow proning and you allow mobilization with that approach, much easier than the femoral approach. Although you can, there are centers where they can mobilize patients with femoral cannulas. Our center has not reached that stage yet, but there are studies that have been published about mobilization with femoral cannulas. Regardless, let's go back to the single site bicaval dual lumen cannulas. So the bicaval dual lumen cannula, there's two commercially available cannulas, the Avalon Elite and the Crescent cannulas. Both of these, as the name imply, are dual lumen cannulas. As you can see, there's a cross section here of that cannula and it's got two lumens. It's a dual lumen cannula. One of these lumens is for drainage. The other lumen is for return. And we call it a bicaval dual lumen cannula because it drains both vena cava. That's why it's bicaval. It drains the inferior vena cava through the tip, and it drains the superior vena cava through a port. And both the inferior vena cava port and the superior vena cava port are both linked to the same lumen, the drainage lumen. And then the return goes back down the right atrium, pointing towards the tricuspid valve into the right ventricle. Now, it's crucial that this cannula is placed appropriately with the tip in the IVC. And try to get the return port and the return jet pointing towards the tricuspid valve. And so, as you can see here, you return to the right atrium, pointing to the tricuspid valve, you drain from the IVC, you drain from the SVC. And that is the bicaval dual lumen cannulation approach. Now, we put it in under TE guidance. You can potentially use transthoracic, but it gets more tricky to see where the jet is going with transthoracic imaging. We usually preferentially use TE to put it in. And so TE is not just to assess where your guide wire is going, but it's very important to see where the tip of the bicaval dual lumen cannula is going. The tip needs to be parked in the inferior vena cava. You need to be able to see the tip in the inferior vena cava. This is actually a transthoracic image, but with TE, it's much easier to see the tip. And you need to make sure the tip is in the IVC. Okay, extremely important. Extremely important. The tip should be in the IVC. So what are the advantages of the bicaval dual lumen cannulation approach? One major advantage, as we said, is patient mobility, as we said in the question. Patients can be extubated and mobilized potentially with an Avalon or a Crescent bicaval dual lumen cannulation approach. As we can see here, this patient is on VV ECMO through a bicaval dual lumen cannula, and he's being mobilized and he's engaging in physiotherapy. Now, he's about to fall, I think, here, and they get him, but still, he's engaging in physiotherapy, which is really good. And that's something that will improve patient strength, patient outcomes. So patient mobility tends to be a good advantage of the bicaval dual lumen cannula. When correctly placed, when the tip is in the IVC, you get less recirculation, okay? Now, it's a single puncture, so that's another advantage of the bicaval dual lumen cannulation. Now, what are the disadvantages? The disadvantage is that usually because you have two lumens in a single cannula, you usually have lower flows, hence less support. If you have a 31 French bicaval dual lumen cannula, that'll give you up to 5 liters. Whereas with a fem jug approach, you can get usually higher flows than that as well. So placement usually requires TE guidance, and that's another disadvantage. If you don't have the expertise, then it can be tricky. You can do it with transthoracic, though, if you are able to get a good visualization of the IVC and visualize the right atrium. Another disadvantage is the price. The bicaval dual lumen cannulas, whether it be the Crescent or the Avalon, are both more expensive than two single lumen cannulas. So it's $2,500 US for the bicaval dual lumen Avalon versus $400 US for two single lumen cannulas, $200 each. So there is a price tag that comes with the bicaval dual lumen cannulas. And so what is the advantage of the bicaval dual lumen cannula? As we said, it allows prone positioning and allows early mobilization. It obviously needs imaging during insertion, so E is incorrect. It really does need imaging. In fact, TE is preferable. And so the next question here, when you correctly place VV ECMO, which configuration of VV ECMO has the least amount of recirculation? Or which ECMO configuration in general has the least amount of recirculation? Is it the femoral jugular configuration? Is it the femoral configuration? Is it the bicaval dual lumen cannulation configuration? Or is it peripheral VA ECMO? So which of these has the least amount of recirculation? Okay, so this was a trick question. And I'm happy that people actually did get tricked with this question. Because what I did is I actually threw in VA ECMO in the mix. And we know that recirculation is a complication that can only happen with VV ECMO. It does not happen with VA ECMO. In fact, with VA ECMO, you have zero recirculation. You're drawing from the vein and you're pumping back to the artery. Where would you get recirculation from? And so the correct answer was actually D, peripheral VA ECMO has zero recirculation. Obviously, we know that the bicaval dual lumen cannula, if correctly placed, has less recirculation than the other setups, but VA ECMO has zero recirculation. And so the answer, because that was a trick question, is actually VA ECMO, because recirculation does not happen at all with VA ECMO. Recirculation is a complication that is unique to VV ECMO. All right, so I'm happy that I was actually able to trick some people in this question. So let's move on. So when you look at VV ECMO configurations, we mentioned here that when it comes to flows, you'll likely have less flows with the bicaval dual lumen cannula. You'll likely have less recirculation if it's correctly placed. Mind you, the problem is if it's incorrectly placed, you'll have massive recirculation. So if the tip is not in the IVC, if the tip is in the right atrium, and you'll be drawing blood from the right atrium and pumping blood back into the right atrium, you'll get massive recirculation with the bicaval dual lumen if it's not placed correctly. It has to be placed correctly, and in that case, you'll get less recirculation. And so let's move on here. So yeah, the correct answer to that, which configuration has the least amount of recirculation? It's VA ECMO, because obviously it has, VA ECMO has zero recirculation. So going back to the configurations that we went through. So after it's all said and done, and after you've placed your cannulas, you need to get an X-ray, and you need to see the tips of both cannulas. Mind you, a lot of times there's a bit of a radiolucent tip that is not visible, so you can add a few centimeters, but it gives you a rough ballpark of where the tip is sitting. With a femoral jugular approach, we can see here that we're draining from the IVC, and we are returning to the right atrium by the jugular vein. So that's the fem jug approach. And you need to look at the distance between both, make sure the distance is about 10 to 15 centimeters. Now, with the fem-fem approach, you will be draining from the IVC lower down, and you'll be returning to the right atrium, also through the opposite femoral vein. And so you need to make sure here that the distance is also at least 8, but preferably 10 to 15 centimeters, so that you don't get recirculation. With a bicaval dual lumen cannula, you are draining both the inferior vena cava and the superior vena cava, and then you're returning into the tricuspid valve through the right atrium. So that's basically the configurations. And on X-ray, you need to be sure that the tips are in appropriate position. With a bicaval dual lumen, you should make sure that the tip is below the diaphragm in the inferior vena cava. I'll share with you a case here where I was called to see this patient had massive recirculation. He had a bicaval dual lumen cannula in place. And I did a TE. And you can see here that the inferior vena cava has no cannulas in place. So we said the tip of the avalon should sit in the inferior vena cava. This is the hepatic vein. This is the IVC. And we see that there's no tip of the avalon here. The tip was actually back into the right atrium. So this patient had massive recirculation because the tip was where we were draining the right atrium and we were pumping back into the right atrium. So there was a lot of recirculation happening. So in that situation, we had one of two options. The first option would be to leave it in place and just insert a drainage cannula in the femoral vein and use this as the return cannula. The second approach is to try to advance it again. However, I will say advancing it once you take the stiff obturator out is extremely difficult. So the surgeon who had put this in tried to actually advance it, and he was not able to because without the stiff obturator, it's very tough to advance it into the IVC. So it's much easier to put it into the IVC on the initial insertion. Once it goes out like this, I'd go with the second option. I'd put in a femoral drainage cannula and convert this to a return cannula. All right, so back to our case. And I'll finish off with my final question about this case. This was a 38-year-old male with ARDS secondary to Legionella pneumonia. He's 170 centimeters tall and he weighs 85 kilos. He did not respond very well to proning. The patient had a persistent fever, and with that fever, he had a hyperdynamic circulation. On point of care ultrasound, his cardiac output was calculated to be 11 liters per minute. So he had a hyperdynamic circulation with the ongoing fevers, and the ECMO team arrives and decides for a VV ECMO. So this is my final question. Let's pick our priorities here. For this patient, who's a little bit on the heavier side, 85 kilos, who has a cardiac output of 11 liters, which VV ECMO configuration would you choose? Would you choose a femoral jugular configuration, or a femoral-femoral, or bicaval dual lumen, or you would not go with either, you would just go with peripheral VA ECMO? So which option would you choose in this patient? All right, so 77% chose the answer that we chose as a team. And so as a team, we chose to go with a femoral jugular configuration. And the reason was we wanted the maximum amount of flow for this patient. His cardiac output was 11 liters. And so ideally, you want your flows in the ECMO to be 60% of the patient's cardiac output or above. Like anything above 60% of the patient's cardiac output will likely give you good oxygenation. And so we decided to go with a femoral jugular configuration. And so what we did is, given the metabolic demand and the cardiac output, we did a fem-jug configuration. So as you can see here, the return cannula is in the jugular vein sitting in the right atrium, and the drainage cannula is in the IVC, and it's a multi-stage drainage cannula. Now, mind you, despite going with a femoral jugular approach, this patient still had persistent hypoxemia. So we went with a two-site approach, fem-jug. Post-insertion day 1, PaO2 remained 53 on an FI2 of 100% on the ventilator and an FDO2 of 100% on the mixer. ECMO flows, the maximum we're able to reach was 5 liters despite having a fem-jug approach. And so 5 liters does not make up 60% of his cardiac output, it's much less. So he remained hypoxemic despite a fem-jug configuration. And every time we tried to increase the flows and the RPMs on the ECMO, we would see shatter or kicking or drainage insufficiency. So we're not able to increase the flows beyond 5 liters, which is obviously not meeting his demands, and he's still persistently hypoxemic. And so my colleague, my colleague who was on the ECMO team at the time, decided to put a second drainage cannula in the left internal jugular so that we would drain both the lower body and the upper body. So now we're draining the inferior vena cava, which is about 60% of the cardiac output, and we're draining the upper body here, Now, obviously, the problem is that drainage cannula should not be too deep. If it goes too deep and it goes into the right atrium, you'll get recirculation. So it needs to be higher up. And so my colleagues decided to put a second drainage cannula in the left internal jugular. That was the option he chose. Another option would have been to put another second drainage cannula in the opposite femoral vein. You could do that. And that way, at least you capture more venous drainage, or at least 60% of the venous drainage going to the heart comes from the lower body. And so you could have tried with a second femoral drainage cannula. My colleague decided to go with a left IJ, and it worked beautifully. That left IJ, because it was now capturing the upper half of the body as well. And so with that, now we have drainage from both the right femoral vein, inferior vena cava, through the right femoral vein, and the upper bodies through the left IJ, and the tip was sitting in the brachiocephalic, and then returning to the right atrium through the right IJ. That was a 3-site approach, and our ECMO flows with that, we were able to get up to 6.5 to 7 liters, which was better for him. We met his needs. His PaO2 is now 61 on an FiO2 of 60% on the vent and an FiO2 of 100% on the mixer. And so we were able to meet his needs more effectively with higher flows when we added a second drainage cannula. But this patient eventually improved and was decannulated on day 17 of the ECMO run, and he was discharged home on day 43 of his hospital admission. With that, I will thank you, and I'm opening it for questions.
Thank you, Dr. Higazi, for that truly great, updated, and informative lecture. We will now open the floor for questions from our candidate. We already have questions in the question chat box. First, there is a question here from me. Can we prone with all configuration?
Can we prone with all configurations?
All configurations.
Yes, it's possible with all configurations. I personally, in my center, we don't do it, but there are centers that do it. And we actually have an invited speaker who's going to specifically address that and talk about proning with VV ECMO. Mind you, there is a study that came out in JAMA last year that randomized VV ECMO patients with ARDS to proning VV ECMO versus VV ECMO alone without proning. And they found no difference in outcome. So there was no difference in mortality between those who were proned on VV ECMO and those who were not proned in this randomized control trial that was published last year in JAMA. However, if you like to prone, there are centers that do that, not my center, unfortunately, and we do have a speaker down the road who will talk about this.
The second question should be the flow rated by membranes. I think he asked about the flow rated, the membrane itself. The flow will be limited by the flow rated of the membrane.
Yeah, so the rated flow, that's a good point. It's a very good point. So the rated flow basically detects the oxygenating capacity of the membrane oxygenator. So if the membrane oxygenator has a rated flow of, say, 6 liters, that's as much deoxygenated blood that the membrane oxygenator can oxygenate effectively, is 6 liters. If you go beyond 6 liters, you're unlikely to oxygenate all the blood. Yes, the flows will sometimes be limited by your rated flow. So that's a good question. In the hypoxia algorithm, now we have an entire talk on the hypoxia algorithm by Dr. Raj Ramanan, who's the education director for ELSO. He's giving us a talk on hypoxia on VV ECMO and how to deal with that. And so if you were to need higher flows, stay tuned for the talk with Dr. Ramanan. There are reports out there of adding a second oxygenator if you had that much flow, or adding another circuit, like having 2 circuits. But I'd advise you to wait till Dr. Raj gives his talk, Ramanan, and he'll be talking about that in detail.
After that, why the correct answer of least recirculation is peripheral VA ECMO, while there is no recirculation at all? It's a tricky question.
Yeah, because there's no recirculation with VA ECMO. It doesn't happen.
At all.
It simply does not happen. It's not a complication of VA ECMO at all. The VA recirculation is a complication that is unique to VV ECMO. It does not happen with VA ECMO because you're basically drawing blood from the venous side, you're returning blood to the arterial side. There's no connection between both that is close by. You don't get recirculation with VA ECMO.
FEM provide higher flow. Why not that? I can't understand. It's not clear.
So FEM gives you good enough flows. It gives you up to 6 liters or so, but you wouldn't get much higher than that. Now, obviously, 6 liters is quite good if you're able to get 6 liters. But theoretically, at least theoretically, you can get higher flows with a FEM jug approach because your return cannula is much shorter with a FEM jug approach. So you have less resistance in your circuit.
So we have here question, why not the bicable configuration from the beginning?
Yeah, so that's a good question. So a lot of centers will go with bicable as their default. I know some centers who will go straight to bicable dual lumen as their default, given the advantages and given all that. But I will say, if your patient has a high metabolic need and high metabolic demand, like their cardiac output's really high, you will not be able to match their cardiac output with a bicaval dual lumen. And so during the times of COVID, that was a good example where initially we used to put bicaval cannulas in these COVID patients until we discovered that their metabolic demand was so huge. Most of these patients had very high cardiac outputs and high metabolic demands that the flows that you can run through a bicaval would not meet the patient's needs. And so we ended up converting to FEM jug approaches during the COVID era because we wanted the highest possible flows because these patients were very hypermetabolic. But
Can you accept?
some centers do go to bicaval. You're absolutely right. Some centers will say bicaval is always my go-to, my first approach, and if it doesn't cut it, I'll put in a second drainage cannula in the femoral vein. But it's a good point.
Can you explain how you connect the added cannula? Dr. Masri already answered this question. If you need more clarification, please chat box. Also here, the right atrium size is 5 centimeter. How the distance should be 10 to 15 centimeter. Answered this question. Can we increase the flow of ECMO more than the rated flow of membrane?
Yeah, so we spoke about that. Stay tuned for the next lecture with Dr. Raj Ramanat. I think we'll move on, and thank you very much for your attention.
Thank you. Once again, I would like to thank Dr. Higazi and the attendees. Now we will go to the second session today about an important topic, so I will give the mic to Dr. Rezan. The mic is yours.
Honor to introduce Dr. Ahmed Labib, Senior Consultant in Medical Intensive Care Unit, Hamad General Hospital, Doha, Qatar. Dr. Shahata is an accomplished clinician and educator holding fellowships from Royal College of Anesthetists and Faculty of Medicine, Faculty of Intensive Care Medicine, as well as European Diploma in Intensive Care. He has extensive expert in the management of critically ill patients in complex and high acuity settings, with a strong commitment to advancing evidence-based practice in critical medicine. This evening, Dr. Shahata will address subject of considerable clinical relevance, oxygenating the circuits but leaving out the patient. This topic highlights potential pitfalls in extracorporeal support, where the focus on circuit parameters may overshadow the ultimate goal of ensuring adequate oxygen delivery to the patients. We are privileged to benefit from Dr. Shahata's depth of knowledge and experience on this matter. Please join me in extending warm welcome Dr. Ahmed Labib, and let's go.
Thank you so much for the kind introduction, and I hope you can hear me clearly. It's very difficult to give a presentation after Dr. Ahmed Higazi, given his excellent presentation skills and the content, the depth and width of his knowledge, and his particular and amazing slides. And alhamdulillah, yani my presentation will become much easier after his presentation. So the topic I'm going to talk to you about tonight, probably for the next 20 to 25 minutes, is about recirculation. And it's one of the reasons why you may have a patient with persistent hypoxia on VV ECMO. So it's one of those things that happen exclusively on VA. You will never see recirculation on VA, as Dr. Higazi alluded to, and it's one of those things. So without further ado, I have no conflict of interest, and the objectives of this presentation is to go through some definitions, the etiology, how you diagnose the recirculation how you manage it. And the session is going to be interactive. There will be some MCQs. I'll throw some questions at you as Dr. Ahmed did, and hopefully I'll get some answers out if you're still following. So the first case, we have a typical 43-year-old patient admitted with severe community-acquired pneumonia, and you did all the right things that you typically do. So you've started the usual high flow nasal cannula, non-invasive ventilation. Then the patient deteriorated, intubated, mechanically ventilated. You started deep sedation and paralysis. Prone position was trialed, and despite all this conservative and trial of protective lung ventilation, it didn't work. VV ECMO was initiated, and it's day one. And in the setting of your center or my center, FEM cannulation was initiated and contemplated without any complications, whereby a 25 French drainage cannula was inserted in the right femoral. It was inserted at 40 centimeter skin mark, and a 21 French return cannula for oxygenated blood was inserted in the contralateral femoral vein at 45 centimeter skin mark. However, despite this, the patient remained hypoxic post cannulation like an hour later, and the saturation was in the early 80s. And then I asked my team, what information would you like to know and what test would you want to order? And these are the choices. So I would like to ask you now, if you are in my center, which single investigation would you like to order now to see why the patient is hypoxic? Okay, so the majority have requested a chest X-ray, not a blood gas analysis, which I believe is the right answer. And probably a blood gas will confirm the finding that the patient is hypoxic, and you have already seen this from the console of your machine. And a pan CT is not going to add any information at this stage. Bronchoscopy is no value, and the clinical diagnosis is obvious. Okay, so you have done an X-ray. So what can you see on the chest X-ray? It's this. Okay, and this is what you have seen, is that the two cannulas are in close proximity, as Dr. Ahmed alluded to in his presentation, that the two cannula tips are in close proximity. And this is probably what explains the hypoxia in this case. So we have another patient who was 19 years old, and he was admitted with severe necrotizing pneumonia, a BVL. The patient was morbidly obese, he was in septic shock, and the main pathology here was septic cardiomyopathy and very low ejection fraction. And the patient was initiated in VA ECMO, peripheral VA ECMO by the team. However, a couple of days later, the patient remains hypoxic. And so we thought about what could be the next step. So the patient was hypoxic on VA ECMO 2 days down the line. So what would you do in your center for a patient with VA ECMO and hypoxic? Choose all the correct answers. There is no single answer here. What would you do? Okay, so that's absolutely right. So in most instances, you have to ensure that if the patient is not adequately sedated, you ensure that the patient is properly sedated. You probably will use something like a BIS monitor to ensure that the BIS score is between 40 to 60. You ensure that deep paralysis with a train of 4 of 0 to -1. You may try bronch position, which we religiously do in my center with all configurations. Our team is well trained to do bronch position, and it works very well in our center. Nitric oxide has been used with various degrees of success to buy time as a selective pulmonary vasodilator, or you can go for a hybrid configuration and add another limb. So what we did for this gentleman, that we added another venous limb, and his cardiac function has improved, and then the arterial limb was decannulated on day 3. However, despite adding a venous limb on day 3, he remained hypoxic, and then we thought what we do. And this was his repositioning of the cannulas, and we pulled the jugular cannula a little bit, and you see the difference between this X-ray and the other X-ray for the other case. And now the lines are quite distant apart. And when we did this simple intervention, his hypoxia has improved. And this takes us to the next question. On VV ECMO, it's a different story. So if you have a persistent hypoxia on VV ECMO, it's different from that on VA ECMO. And for persistent hypoxia on VV ECMO, we do something different. Okay, so the patient now is persistently hypoxic on VV ECMO, and the question now, you have passed the stage of sedation, paralysis, and diuretics, and you now think about the prone position and adding another venous limb on VV ECMO, and the options are a little bit more limited now. So what are the recirculation, or what defines this recirculation? It's where your oxygenated blood that's coming from the machine is sucked and returned to the machine before actually reaching the patient. So this leads to a systemic hypoxia and patients becoming less oxygenated, and the oxygen delivery is impaired. So the machine is doing the job, it's oxygenating, the membrane is functioning well, but that oxygen is not reaching the patient because of the shorter distance between the two cannula that you have inserted into the patient. And this will lead to the systemic hypoxia. The circuit will be working too much or overloaded, and the ECMO support will be limited. And the main predisposing factors for this are, the most single important factor is the cannula positioning. So if the two tips are in close proximity, this will lead to recirculation. Other factors are the higher ECMO flow rates with a low cardiac output working simultaneously, and if the patient is relatively hypovolemic. And this diagram probably you have seen in the previous presentation by Dr. Ahmed. And as you see here in the classic FIM-FIM approach, if the access and return, or the drainage and return cannulas are in close proximity, so this is your venous blood and this is your oxygenated blood, and it's coming here, and the sucking forces from the cannula are working here. This oxygenated blood will not come into the RV. It will come back into the machine, to the membrane. It will not reach the patient. However, if the distance is far apart, and we'll talk about, this oxygenated blood will go into the patient. So this explains what happens in the FIM-FIM approach. And also in the FIM-JUG approach, this what happens if they are in close proximity, the IVC and the SVCRA, and the distance has to be adequate. Otherwise, this oxygenated blood will go straight into the drainage cannula, into the machine, and recirculation happens. And this is one advantage of the bicaval or dual cavity cannulas, where the phenomena of recirculation is as little as possible because of this. And this is another cartoon or diagram that explains the phenomena in more details, where the oxygenated blood is pushed here, and if the distance is too little, it can go straight into your drainage cannula. So how you diagnose recirculation? This is another question for you. And if you are at the bedside, so how can you diagnose recirculation? Is it the increase in end-tidal CO2, or the pre-membrane, or loss of color differentiation? We said there will be systemic hypoxia. So this question might be a little bit ambiguous for you. Loss of color differentiation, and when you have the two tubes are exactly the same color, this is loss of oxygen supply. Oxygen failure, this is the only explanation for complete loss of color differentiation. So this is not the correct answer. But when you have a decrease in the pre-membrane oxygen saturation, this is the correct answer for this question. It's not the loss of color differentiation. So it's a systemic hypoxia, where you have a pre-membrane oxygen saturation that's increasing, and the post-membrane saturation that's decreasing. So the correct answer is C, decrease in post-membrane and an increase in pre-membrane. So this is the systemic hypoxia. But loss of color differentiation is the diagnosis of oxygen source failure. And this is what happens. So you can exclude meaningful recirculation, because some degree of recirculation will always happen with VV ECMO. And it's inevitable. 5 to 7% of recirculation would happen with any, and the 5 to 7% of recirculation is typical for the dual lumen cannulas. And with other configuration, it can be up to 15-20%, and this is typical for a FEM or a FEM jug. It depends, because the other physiology of the patient, like the variation in the volumic status or the variation in the cardiac output or the ECMO flow, will lead to that recirculation. But always expect some degree of recirculation in your patients. However, we can reliably exclude meaningful recirculation of your pre-membrane BO2 is less than 42 millimeter mercury, and the pre-saturation is below 75%. And this slide summarizes what happens there. Access and return cannula are close to each other. The patient is hypoxic and the pre-saturation is high. So the patient is hypoxic, but you look at the console and the pre-membrane saturation is high. And how you manage that? You reposition the cannula or you opt for a bicaval. How you diagnose again? So you compare the oxygen saturation at different points in the circuit, and you can estimate recirculation. You look at the pre-oxygenator saturation, and this reflects the oxygen content of blood entering the circuit. And you look at the systemic venous saturation, which is the patient's systemic venous saturation, and the difference between the two, the pre-saturation and the central venous saturation, suggests recirculation. And then you can calculate your recirculation or the recirculation fraction by this equation. So it's the pre-membrane saturation minus the central venous saturation divided the post-membrane minus the central venous by 100%. And if you have the pre-membrane equaling the central venous saturation, so this is 0, so the whole recirculation fraction is 0. Or on the contrary, if the pre-membrane is equal to the post, it's 100%, which should never happen. How we measure this? So apart from the saturation at different points in the circuit, and you get all the information from the console in a CardioHelp or a Xenius machine. Other techniques include the ultrasound dilution technique or the thermodilution and lithium dilution technique. Both these are kind of research, less clinically applicable and more difficult and time consuming. So I rely on the saturation measurement in different points of the circuit and to calculate the recirculation fraction. Dr. Ahmed spoke in depth about this, but this is a summary of all the different configuration for a VV cannulation. So we have the FEM jug. So when you have the drainage, usually the first abbreviation or the first letter refers to the drainage cannula. You can drain the blood from the femoral and return into the IJ. This is one of the most common configuration, and in many centers this is the standard, and this has the lower rates because there is usually a big deal of distance between the cannula tips and the chances of recirculation are low. Some places I haven't seen this, but you can have a jug FEM. So you drain from the internal jugular and return into the femoral vein, and higher rates are observed here. The FEM is the classic. We do this in my center because if there is any CPR going on and if there is any airway interventions happening, we do the cannulation in the lower half of the body, other people dealing with the upper half, and you can leave the jugular veins for central line access, for dialysis lines, for another ECMO line insertion if needs be. We typically go FEM as our preferred approach. And here the recirculation is variable and you have to be careful with the positioning. And then you have the dual cannulas like the Avalon Elite or the bicaval, the new ones like the Crescent or the Vortec Dew. And here the recirculation rate is lower or very minimal with the Vortec Dew. Then have another question to you about the prevention of recirculation. And I would like you to choose all the correct answers here, how you prevent recirculation. So would you keep the cannula tips 3 to 5 centimeters, or to use the ultrasound rather than fluoroscopy, or you keep the cannula tips 7 to 10? There is one point, is it 5 to 7 is inevitable, or the jug FEM is better than the FEM jug? Okay, so the correct answer is keep the cannula tips at least 7 to 10 centimeters, as we discussed before, and this is the correct answer. Thank you. The flow dynamics, again, we talk here about the relationship between your cardiac output and the ECMO flow. So it's generally recommended that we maintain as low as possible an ECMO flow, because the higher the ECMO flow, it's not just the shear forces that you apply to the blood and the increased risk of hemolysis, and it's not only that this leads to more coagulopathy, but also the higher the ECMO flow relative to the cardiac output is the higher risk of recirculation. And it has been observed that with a higher rate of ECMO flow, that also the risk of hypoxia because of the recirculation becomes much higher. So try and avoid the increased ECMO flow unnecessarily on your patient because of the risk of recirculation and other problems associated with it. So how you manage a patient with recirculation, there are several things to consider. The most important thing that you manage this is by repositioning cannulas and making sure that they are separated, as discussed before. Reduce your ECMO flow if clinically acceptable, and switching to a dual lumen. However, as Dr. Ahmed Higazi alluded to, the maximum flow you can achieve with a dual lumen is 4 liters per minute, and this is not enough in hypermetabolic patients, and optimize your volume status and cardiac output. Hypoxia on VV ECMO with a relatively stable patient. This is a very interesting slide. So you look at your pre-membrane saturation. If it's high, above 80%, this is definitely recirculation. So the first condition, when you have a hypoxic patient on VV ECMO, the first thing I look at, nurse calls me, this patient is hypoxic, I look at the pre-oxy or the pre-membrane. If it's above 80%, for sure, this is recirculation, no second thoughts. Second, if this pre-oxy is normal, I look at the post-oxy. Is it normal? Okay, now I look at the second most common pathology with a normal post-oxy, it's increased intrapulmonary shunt. Means that the lungs are knackered, the lungs are still bad. I look at things that deal with that. I consider beta blocker, wrong position, recruitment maneuver, or increase the ECMO flow. If the post-oxy is low, less than 200 millimeter mercury, this is about oxygen transfer. I look at the oxygen transfer. If it's low, this is membrane failure, change the circuit. The third option, or the third possibility for a hypoxic patient with a pre-oxy that's low, I look at the post-oxy. If both the pre-oxy and the post-oxy are low, this is about oxygen transfer. I look at the oxygen transfer, so it's membrane failure. And then if the oxygen transfer is normal, it's about these other two possibilities. So this is the flow chart, and this is something that we use in our unit as a standard of persistent hypoxia on VV ECMO. When you start a patient on VV ECMO, you expect that the patient will improve. Not all of them will improve and become with near normal acceptable saturation. Some of them will keep you awake most of the night because they remain hypoxic. If you have this pictorial chart in your head about a hypoxic patient in ECMO and what you can do in the middle of the night, or not you personally, but your junior staff on the unit can do, this makes your life a lot easier. Check your pre-oxy, check your post-oxy, and then have this different management strategies. You don't apply all the management strategies to the same patient. You have to tailor your management strategy according to the patient condition. Another thing that I just wanted to allude to, because you have hypoxic patient on ECMO, the differential hypoxia is a totally different story. So this is the hypoxia that happens only on VA ECMO. So recirculation, VV, differential hypoxia, Harlequin, north-south is VA ECMO, and this happens again in a different physiology or a different pathology when your LV is ejecting and recovering, and the mix between oxygenated and unoxygenated blood happens with the poor lungs, and this is not recirculation. This is a different story. I'm not going to dwell on that, but I wanted you to be aware that hypoxia in VA ECMO is different. So in conclusion, there are effective strategies to minimize recirculation, which include, first and foremost, optimal cannula position. You have to ensure adequate distance between the tips, the drainage and return cannula, at least 8 centimeters apart, to prevent the immediate re-entry and sucking of oxygenated blood into the circuit. You have to control your flow rate, the ECMO flow rate, avoid very high ECMO flows that can encourage the turbulent flow and recirculation. Select your cannulas properly, as in size and length and depth of insertion. Use your fluoroscopy. I always encourage fluoroscopy and X-rays. Ultrasound is different story. Ultrasound will help you to avoid complications, help you the first pass access, decide on the how many French Sharia use for the cannula size, etc., the depth and the direction of the veins, but not for the distance between the cannulas. And you have to regularly and continuously monitor your patient saturation, etc. And with this, I finish the presentation and thank you. And thank the organizers for inviting me and wait for your questions.
First question from him, please explain how the intrapulmonary shunt changes the pre and post oxygenation. And second, how also you can get the saturation pre and post.
Sorry. So intrapulmonary shunt, sorry, I'm just a little bit of. Thank you, Dr. Ibrahim. So intrapulmonary shunt means that your patient's lungs are not recovered yet. And it means that if you have a process of consolidation, if you have a process of lung infection, whatever the cause is, it's still not fully recovered. And with that, you need more support from ECMO. And those patients will remain hypoxic for a little longer and will need more support. And this means that the pre and post membrane saturations will remain low and your systemic oxygenation will remain low. Sometimes those patients need another venous access or another cannula to support them. Those patients are typically more septic and their cardiac output may be higher. And with that, they have a cardiac output of 8 or 9 liters and the ECMO flow is 5 liters. I personally, when I use the CardioHelp in theory, can give you 9.99 liters, but it cannot deliver 9.99 liters. And in this instance, you add another venous limb, you achieve 7 or 8 liters and the hypoxia will improve. So the intrapulmonary shunt is the VQ mismatch. It's bad lungs, as simple as that. How you measure that in the machine, it will give you the pre and post membrane saturations, or you do a pre and post membrane gases. So you take from the pre-membrane blood gas, the post-membrane blood gas, and the machine on the console will give you the SVO2.
Second question, mixed venous saturation need pulmonary catheter. So do we need pulmonary catheter for VV ECMO?
No, the machine, the CardioHelp will give you that the central SVO2 is measured on the machine. So there is the central venous saturation and the mixed venous saturation. We shouldn't be mixing the two together. So if you'd like to have the mixed venous saturation, you get it from the machine. The central venous saturation, you get it from any central vein. The mixed, the pulmonary artery catheter is for the other measurements. So, and the difference between them is 2 to 5%. And it's negligible in most clinical scenarios.
Yes. It's commonly we are used the mixed venous saturation for pre-oxygenated saturation. If we are trying to get mixed venous saturation, we have to put pulmonary artery catheter, but for recirculation, it doesn't mean that we can take mixed venous saturation, just pre-oxygenation saturation. Yes.
That's true.
Do you clamp the circuit to get the true venous saturation in order to calculate the recirculation fraction?
No, we never do that.
Yes. I learned very important information. Thank you. It's possible to see that. Okay. How do you manage high cardiac output?
This is the slide I showed you. So there are a few things to do. Beta blockers, ultra short acting beta blockers, especially esmolol. If the patient's heart rate is 120 to 130 and you know the cardiac output is the product of stroke volumes time heart rate. So the first strategy is to reduce the heart rate. If the cardiac output is high because of high temperature, you reduce the temperature by cooling measures. If the high cardiac output because of the patient is lightly sedated or unparalyzed, you tackle that. If the high cardiac output is because the patient is anemic, you tackle that with blood transfusion. So you try and find the reason for the high cardiac output, but if the patient is quite septic and this is because of the inflammatory response to sepsis, you treat sepsis as you would and you give it time for the sepsis to settle. And sometimes it's very difficult, but our first line is esmolol, cooling measures, good sedation, deep paralysis, etc.
Okay. What does oxygen transfer refers to, Dr. Islam?
Oxygen transfer, the famous equation as the oxygen transfer is the oxygen transfer constant, which is 1.34 times the hemoglobin concentration times the saturation, in addition to the oxygen dissolved in solution, which is 0.23 times the oxygen tension. So this is the oxygen transfer in blood. So you calculate this and you time it by the cardiac output, and this gives you, typically there are 200 mils of oxygen transfer per liter, or 1000 mils per the whole cardiac output. This is the oxygen delivery and oxygen transfer.
Another question from Dr. Anam is a good question. Can post-membrane oxygen be low with good oxygenator work?
No. So one of the things that we do in our unit, so we do blood gases 3 times a day at the beginning of every shift. That's pre-membrane. We do the pre-membrane 3 times a day. We do the post-membrane once daily in the morning at the beginning of every shift. The post-membrane tells you about the membrane function. So if the membrane is poorly functioning, your post-membrane will be very low because the membrane is not functioning. And we compare this every day. So if you have a post-membrane that's not improving, this means that the membrane is failing over time in addition to the delta B. So you have to do that.
Dr. Ahmed, I remember one of our cases 12 years back. The oxygenator was working well, but the problem was in fresh gas flow and the mixer, which was very simple, but it missed from the perfusionists. Yes.
Yeah.
Remember which mandate superior? What does it mean? Don't know. Dr. Ahmed Al-Masri, remember high cardiac output is protective against recirculation, but might lead to systemic hypoxemia. Low cardiac output increase the recirculation ratio.
Yeah. It's a double-edged sword, so you have to be careful. Too high flow against a low cardiac output, too low flow against a low cardiac output. So it's a fine balance. So that's why if a high ECMO flow is not needed, don't go for a high ECMO flow. And be aware that a very low cardiac output with a high flow increases recirculation. So tailor this to the patient need and avoid any unnecessary high flows if not needed.
Alex said, excellent presentation. I agree with that. Thank you, Dr. Ahmed.
Thank you so much.
Thank you, everybody. I appreciate everybody's attendance today. It was a really good discussion there, and I like the Q&A. There's a question about what the acceptable patient saturation is. It's basically what meets your needs. Most people will accept SATs above 85%, but you need to check your lactate, check that they're meeting the patient's needs. Thank you, everybody, once again. If you'd like to register for the course, I've been told here it's not too late. You can join the ECMO MCS course. It's an asynchronous course. You could watch the lectures at your leisure. And this is the 4th week of the 12-week course. Thank you all for attending once again. Thank you for our moderators for the fantastic job. Thank you to our speakers. I want to ask Dr. Ahmed Labib, really enlightening presentation. I really enjoyed it. And thank you to our attendees who have stayed up late to watch us tonight. And thank you all. Have a good night.
Thank you so much, Dr. Ahmed and the team, Dr. Walid behind the scene, doing all the technical work and our support. Thank you so much. Pleasure and honor to be with you all. Thank you so much. Have a wonderful evening and see you on the next one.
Thank you.